now you were discussing already about that, of course, not all indices might give you the same answer. And so what happens if CBI, TBI, and BADD differ? Professor Zhou, you mentioned already that you, in this case, put the most value on the TBI, right? Yeah.
Yeah. Yes. When the tomography biomechanic estimates, the CBI, TBI, and BADD differ. So I would like to trust the topography's the BADD display. Mostly we can find the eyelids effects with the topography, the pyramids changing. But TBI is much something like TBI is much stable. So when there are difference between the TBI and the BADD display, I will ask the patient to with the eye drops or reference eye drops for 1 to 2 weeks and come back to take another topography assessment.
Yeah, Shizuka, you also sent me a case. Let's just jump into the case. Yeah, it's here of a case where CBI and BADD and TBI differed. So can you comment on this case and bring it in for discussion?
Okay. So as you see here, BADD and TBI actually are based on our criteria. Actually, these are these values are within normal range. But I'm very surprised that only the TBI actually shows abnormal. But in this case, actually, we can repeat the repeat the measurement in next time. But we have some patients actually. When next time the patient come to our clinic, the TBI is actually getting lower, and I think we just actually observe the patient, keep observation.
Okay.
Sven, I'm confused. Go back to the case 2. Do you have the left eye of case 2?
Yeah, no, that were 2 different cases. But case 2, yeah, you see that I think we only have this eye, right, Shizuka?
The other eye has a keratoconus.
Clinical keratoconus.
Okay, so it's a VAE. Yeah, I would say this. Yeah, this is a picture of a patient that does need observation, but at 40 years old, I think the patient will be fine. But it's like you start from a weak cornea that the CBI demonstrates, but the patient did not rub this eye very much. And then the abnormality is on the low range. That will be the case that it's, even though it's 23, it's not a very low number. It's not higher than 20, 25, 29. That will be the cutoff value. So it will be a false, let's say, a false negative on the TBI, but that's the case that I would like to see the new algorithms that we have worked on to improve the TBI with the brain group.
Mm-hmm.
Actually, this patient has no keratoconus related factors.
So, and that was the third case, another case, 36-year-old, right?
Okay. So actually, based on my criteria, BADD is a little bit actually more than 1.6, but CBI is 0 and TBI is 0.2. So it looks like actually sometimes actually kind of BADD value is kind of borderline. Can you hear me?
Yes.
Okay. So actually, I definitely actually I suggest actually come again and measure keep the observation, because it looks like the CBI and TBI are both normal.
Yeah, one thing in this case that's very interesting, you see the shine fluid image. In the nasal part, you see a little high reflective area here. And this is probably a little leucoma. And I tell a lot of colleagues this is very important that you should not forget the slit lamp biomicroscopy. And probably this is a good patient that would benefit from a surface ablation because he has some irregularities on the front surface of the cornea that may be even treated by that if the patient wants to do refractive surgery. But I would never consider cross-linking here.
Definitely, actually, the other eye has actually clinical keratoconus.
Oh, so yeah, that's important. This is one of the cases that we probably, I'm not sure if this case is part of the cohort of the international cases that we train the optimized TBI, but this is very important to think about how is the TBI optimized looking at it in this case.
Okay, Renato, you shared also a case again related to this topic, and it had also to do with ectasia, but this time it was from a colleague, right?
Yes, this I saw this patient for the first time probably 15 years ago. And if you click again, this patient was a patient that did not like the result of LASIK in the left eye, even though in the first month she was 20/25 uncorrected. But she was seeing a lot of glare, a lot of halos, and she decided not to have the surgery in the right eye. And we published in 2010 the mild changes that we would be able to see in the right eye on the Pentacam and ocular response analyzer. And that was pretty much the first time I used the term ectasia susceptibility. And I remember very well George Rain III, who was the editor of the JRS, he sent me an email and say, why you say susceptibility? And I replied to him, this is a very important term and we should all evolve to this terminology. And he finally agreed that the paper would be published, and I always thank him for his wisdom because he inspired a lot of my thinking on the understanding of susceptibility, because he quoted that the ectasia is like edema. It's not something that you have a disease, corneal edema. You have many pathways that you can lead to corneal edema. And some corneas are weaker than others, but it's important to see that edema is a sign like ectasia. And this patient had ectasia susceptibility because we know the fellow eye had LASIK ectasia. And if you see the patient now, many years after surgery, you see the topography is a little bit abnormal. The D is a little bit abnormal. The PRFI with the Pentacam and Corvis is a little bit abnormal. But again, when we integrate the tomography data with the biomechanics, you get the 0.78. And here you see the stiffness parameter is on the between here. The integrated is not looking bad. The DA is on the between the ART-H, but the TBI is 0.78. And this is a very good indicator that the patient had ectasia susceptibility.
Yeah, but it's a perfect example, again, what Riccardo mentioned several times, that the TBI is not at all a combination of CBI and BADD. But more detailed artificial intelligence score using all the data. And as you pointed out, you can see that some biomechanical indices are slightly abnormal, but really abnormal is really the artificial intelligence score.
Yes.
And a very nice example for this as well.
I'm not sure if you have the son of the patient included in this presentation. If you click once again, yes.
Yeah.
This is both eyes of the son of the patient. with 11 years old. This is again, like Riccardo just pointed, what happens if you have both eyes with this picture? And this is a both eyes 2020 distance correct patient with moderate allergy. And this is the kid that should really benefit from the information and education that we should all tell our patients not to rub the eye. That's one of the main concepts in our Violet June campaign. Don't rub your eye. Rubbing is bad for you. A lot of people like Damian Gattinel say that's sine qua non for corneectasia. I would say it's not that much of the case, in my opinion, but it's very important that this patient does not rub the eye because he has very early signs of ectasia susceptibility. And even if you see even the TKC in the left eye would be a possible here. And so this patient even may qualify for asymmetric keratoconus. Going back to how we should manage this patient, should we do cross-linking? I don't think so at this moment. But we have to follow up this patient very carefully so that we don't lose the opportunity to help the patient if the progression occurs.
If we are speaking about family history, I'm going a little bit back, but Shizuka presented also a very nice, interesting case about family history.
Can I comment one thing, Sven, regarding this?
I select the slides for Shizuka.
I think that maybe I'm a little bit out of the opinion of everybody, but I don't think that we should give a message that is which index should you trust in case they differ. Because let's go to another, a completely different subject. So imagine that you're screening a patient for cancer and the CT scan is negative and the PET scan is positive. Do you think that this patient is healthy? No, it's clearly not healthy. So if you have a CBI that is abnormal and the TBI is normal, or the opposite, remember that if you're doing refractive surgery, you're treating a patient that is healthy. They have 20/20 vision with contact lens. And if you do a mistake, then this is for life. So I think that if you have a patient that is abnormal clearly with one of the two, I think that what we should do is at least wait for a good period of time and not saying, well, the CBI is abnormal, but the TBI is 0.35, I treat. I think that we should really be careful because these are healthy patients. We are not treating keratoconus. These are healthy.
Yeah, I don't know whether I think, don't know, Renato, do you want to comment on that? But I think you agree mostly, right?
I agree.
Yeah.
I think when we go beyond the understanding of multimodal imaging towards the understanding of ectasia risk in a broader range, I would say that we are looking at the risk of ectasia progression. And I don't want to take the innocence of everyone here, but there is no zero risk. There is no zero risk. Mathematically, the risk is the denominator. So if you want to have the zero risk in that equation, the equation is impossible to be conceived. So the risk has to be low, 0 point something, that is acceptable to go. And that's a medical decision making. And again, I agree with Riccardo, and I would say I would, in the past, be very emphatic, if probably even more emphatic that as he is, because the concept of iatrogenic medical treatments should be avoided, prima nocere. We always use that. I see Riccardo has a lot of passion on his concept, and I agree with that. But we have to tell the patient about ectasia risk. We have to understand patient age. We look at other factors, why the patient wants refractive surgery.
Absolutely.
Contact lens is a very big issue because the contact lens warpage and I come with a new term of micro warpage, and the patient used the contact lens for a couple of days. It can change the TBI. So, how many days after contact lenses discontinuation should we take? So, all of these factors should be considered, and every case should be individual. We want to treat large numbers of populations because that's our work. We want to help all the patients. But every case, we have to sit and look at the patient eye and take the emotional intelligence into the equation to use the advantage of the artificial intelligence that will help us make a decision for the patient. And that's very important.
Shizuka sent also some more interesting cases also related to family history. And yeah, perhaps Shizuka, you can present this case.
Okay. Okay. So actually, we have one patient. So actually, the 49-year-old female actually, one day actually she brought her three daughters actually to ask me to screen all three daughters. Actually, as you see here, her mother is actually clinical keratoconus. Okay, could you go next? Okay, this is the first daughter. So actually the visual acuity is both sides actually good, and but actually in her left eye actually the first daughter has keratoconus suspect based on the keratoconus screen index. Okay, could you go next? Okay, so second daughter actually so definitely so she had clinical keratoconus based on the keratoconus screening index, and also both definitely left eye shows TBI shows 1.00, and BADD it indicates 2.4.
Yes. May I comment on this daughter as well before you continue? Even so, the CBI here on the other eye, where the TBI is relatively normal, CBI might be not in the complete red, but as Riccardo showed, the sigmoidal curve, it's already in the yellow. So the biomechanics is a little bit abnormal here as well.
So actually, so for the second daughter, left eye actually there is no slit lamp actually finding it actually normal. So actually, I am very confused because both actually only if the left eye has actually clinical finding as normal clinical finding actually we can say FFK. But okay, so could you go back?
No, this is a third daughter now.
Third daughter. Okay, third daughter. So third daughter has nothing in slit lamp, and placebo it was actually both normal, but and also CBI and TBI looks like actually within a normal range. But actually, so what I'd like to emphasize actually, her mother is actually clinical keratoconus, and also her her sisters actually had kind of keratoconus suspect already. So I definitely consider evidence. This is kind of corneal ectasia susceptibility. Renato mentioned.
So perhaps the others would you discuss this? I mean, family history, of course. Yeah, how important do you consider family history of keratoconus?
I think so. So every time actually, we have to think about the questionnaire about keratoconus related. Of course, familial history and atopy and eye rubbing and ocular allergy. Yes, and also sleep face down.
Renato, perhaps.
I love these cases from Shizuka. I think it's very beautifully taken, and I really like the presentations of the bilateral susceptibility of the daughters. And the message here is treat the allergy and don't rub the eye. But this is very simple. You can tell everyone to not rub the eye, but these are the patients that you have to follow up. And eventually the clinical follow-up is very important. And patient education is a must, because we see patients that come for the first time with advanced keratoconus. They would have been at one day like this cases. Eventually we could change their disease clinical pattern if we were able to do that. So it's very important to, this is a beautiful example, and patient family history is a very important factor, but I would say I don't overweight that. If the patient has a history of keratoconus in the family, I would say you're not a candidate for LASIK at all. Of course not. I take the individual consideration of the data, and if the data looks good, the patient may have a keratoconus family positive, but it's not a very major abnormality for me. It's definitely something to be considered, but it's not overweighted in my practice.